Okay, we've touched on staging sleep. Now let's discuss the second half of sleep studies, which is scoring. The equipment and sensors we use for respiratory events include an oronasal airflow thermistor used for apneas. The key prefix here is therm. It measures airflow through temperature change. Nasal pressure transducers use a cannula to measure the pressure, and they are used to measure hypopneas. Respiratory effort belts are used to tell if a patient is trying to breathe or not. We'll see their stomach or their chest rise and fall. That's how we tell the difference between central and obstructive events. Snore microphones or snore sensors not only confirm obstruction with recording the snores, it records the amplitude of snores, how loud or quiet they are. Carbon dioxide retention is another potential issue for pediatrics, so capnography is used and can be acquired through end-tidal CO2 or transcutaneous CO2. As with all respiratory events, you want to know if there is an oxygen desaturation, and for those we track oxygen with pulse oximetry. Finally, and very rarely, esophageal manometry can be used to measure respiratory efforts like the belts. Like I just mentioned, apneas are scored using a thermistor. If it just so happens that the thermistor has fallen off or stops working, or you don't have one, while you're fixing it, you can use that time that's spent on the study can be scored using the nasal pressure transducer. You can also score apneas based on the airflow signal that end-tidal capnographs show. If all else fails, you can detect apneas with the belts. When you put the data of the belts together, the paradoxing effort that causes a flat line, it causes a flat line because the belts going in opposite direction cancel out the voltage that they're giving. Hypopneas are scored using the nasal pressure transducer with a cannula. If the nasal pressure transducer is not functioning, you can use the respiratory effort belts and their functions to show airflow decreases. But you must always have the MPT on, always. That and the pulse ox. Thermistors have the tendency to break and give false signals, especially if they're pressed against the skin. It'll just read the skin temperature. If a pediatric patient is on CPAP therapy, the CPAP has an output that you can connect to a computer, and the CPAP will provide the airflow signal. Effort is still recorded with the RIP belts or esophageal manometry. The manual brings up monitoring oxygen, and to time it all together properly, the maximum signal averaging time needs to be 3 seconds at a heart rate of 80 beats per minute. These are the settings that can be calibrated with the computer software. Snoring can be monitored with a snore microphone or a snore sensor, or you can even set a low-frequency filter on the pressure transducer to 1 Hz, and it'll be a flat line with just the snoring signals. It's a great way to do a snore sensor. Hypoventilation can be measured during diagnostic or PAP titration using arterial or transcutaneous CO2, but diagnostic can also use end-tidal CO2. It's really difficult to measure end-tidal CO2 with a CPAP mask. I've seen it done before, but it required drilling a hole in the CPAP hose and running a beheaded cannula without the nose pieces through a hole, and far enough up into the CPAP mask that it's right outside the nose. Of course, when the patient moves, it doesn't stay, but a lot of labs just don't have the money for transcutaneous machines, and patients are less likely to sleep with an IV and just to collect blood samples, let alone paying a nurse to do it, just for a sleep study. This is a good representation of normal non-REM respiratory effort and flow. The belts are in sync, going up as this one is going up and down, up, down, up, and down. They're not paradoxing, going against each other. The airflow shows nice, full breaths. There's no snore microphone, but if we had a snore microphone, it probably wouldn't be doing anything. The airflow is not showing any signs of flow limitation or snores. There are no visible arousals in the EEG, and the effort looks nice. No desaturations. Here's an example of a typical REM respirations. You may notice during some of the eye clicks, the patient looks like they're having a central hypopnea. Here's some eye clicks right here. Right there, the airflow is down a little bit. Here's where it really happens the most. And the patient looks like they're having a central hypopnea because the effort has decreased. Here we have nice in and out breaths. It's a little low, but that's probably just the size that the technologist has. And then you can see it really decreases here. Really big waves here, smaller here. This happens as the eyes are clicking. This is normal. When you dream and look around deliberately, you're likely to hold your breath, and that's part of the limbic system. When you're in danger or are so focused on one object, you may hold your breath. If you're in danger, it's for stealth or for better focus. Or if the person is beautiful, they took your breath away because you lost focus on everything else but them. You will also notice that there is no real persistent snoring and no arousals. There is a 2% desaturation down here from 96 to 94, but that's not enough. Remember, this is phasic REM. Phasic REM is when the eyes are moving and you have irregular respirations. Tonic REM, like over here, there are no eye clicks. Here's some more tonic REM. Right there. And in between these eye clicks, there is tonic REM. To score an apnea, a few things must be present. The first, the thermistor or PAP flow signal must show a decrease in amplitude of at least 90% from how tall the breaths were before the event started. The duration of the 90% or greater drop in signal amplitude must last at least 10 seconds. A lot of labs won't score apneas unless it's a dead flat line, but everybody's different. To score an apnea as an obstructive apnea, it must be associated for at least 2 breaths as far as the airflow goes, and the respiratory effort must be there the whole time. They must be trying to breathe, and you see the trying or effort in the belts. Anytime we're talking about trying to breathe or they're not trying to breathe, that is effort in the belts. For the duration, it's easier to score apneas for pediatrics because they almost certainly will breathe several times in 10 seconds. So 2 breaths opens the door for pretty short apnea scoring. Remember that obstructive apneas do not require a desaturation or an arousal. This is an adult record, but it still shows the exact same thing you would see in a pediatric obstructive apnea. The belts do not have to paradox to have an obstructive event, and a lot of times the belts will move from the original position when the patient moves around. So they could settle at the waist by the time the study's over, and you won't have any paradoxing there. You can also tell this is a legitimate apnea because here the snoring stops, and there is no airflow at all. They can't even get snores out until right there. And then they get nice full breaths. And I'd put the arousal over here. There's more alpha here, but this is where the ISR would score it. And right here, this is the nasal pressure without a signal filter on it. So this is the native signal, and that's what that darkness is there. Those are snores. A lot of labs will use a filter on it so that it'll just be a straight line, but that's taking out the snore artifact, which is you can still count this as a decrease in amplitude. So that's that. Speaking of duration, this is an adult, and adults don't breathe as frequently as pediatrics do. This event lasts 4 breaths, so you could, that's still, and it's associated with a heavy desaturation and an arousal. That goes down to 89% from 96, so that's pretty good. Central apneas are scored a little differently. There must still be the 90% or greater signal amplitude loss, but the effort belts must also lose their effort. You want 3 flat lines, 4 if you include the nasal pressure transducer. The duration is different than obstruction. You can either have a central apnea by itself with no desaturation or arousal that lasts at least 20 seconds, or you can have a central apnea that lasts 2 breaths and is associated with an arousal or 3% or greater desaturation, kind of like an hypopnea. Infants, on the other hand, have the added stipulations of if the heart rate reduces to less than 50 beats per minute for at least 5 seconds, or less than 60 beats per minute for 15 seconds, that can override the 3% or arousal, or the 20 seconds. These are the things you need to write down, because if you can draw what these things look like, then you understand what you're looking for. These are back-to-back central apneas. These are from an adult record, but the most important part is that there is no effort. That is dead flat. Flat lines in the chest, the abdomen, and the airflow. And then they have these again. This is very similar to Shane Stokes breathing. Here's an interesting issue. Normal healthy individuals take in a big breath from time to time, and it's a sigh. It's believed to help stretch out the lungs and keep them from becoming rigid while you sleep. This is an example of a sigh. This person's on CPAP. This is a CPAP flow, and all of a sudden, and after you take a big breath in, usually you don't breathe for a little bit because you took in enough air for a few breaths and you don't need to breathe anymore. That's a normal physiological thing. Sometimes it's associated with a desaturation. This is a very controversial issue amongst doctors and sleep technologists. Do you score these or not? You've got both sides. And a lot of times these are happening after an arousal. So you have to have 10 seconds of sleep, which, that's very close to 10 seconds. When unsure, go ahead and score the event, even if the physician doesn't think it's a real event. It could provide a high enough AHI for the doctor to at least have diagnosis options in case the patient does have real apnea. The same thing occurs in REM. REM centrals are a common thing. Should you score them or not? REM is irregular, so it's hard to force the patient into regular breathing with just CPAP because those things just programmed, and especially ASV, those just do what's programmed. They can't predict when the patient is going to breathe again in REM. The REM breathing is very spontaneous, so you can open the airway for patients in REM, but you can't really force patients to breathe, especially in phasic REM. The last kind of apnea is a mixed apnea. That's when part of the event is central in nature, meaning no effort, and part obstructive in nature. And it doesn't matter which is 50-50 or if which comes first. It's a mixed apnea. If the apnea or hypopnea event begins or ends during an epoch that is scored as wake, then the corresponding respiratory event can be scored and included in the computation for apnea-hypopnea index, the AHI. This situation usually occurs when the individual has a high AHI with events occurring so frequently that sleep is severely disrupted, and epochs may end up being scored as wake, even though less than 15 seconds of sleep is present during the epochs. It should not be scored or counted during the AHI because the difficulty of defining the denominator in this situation. Are they going to sleep and having apneas, or are they having apneas or going to sleep problems? Difficulty. If these occurrences are a prominent feature, if they stick out and it's a real issue, and they interfere with sleep onset, mark those down in the summary of the study. Here are a couple of mixed apneas. They begin with a central component right there, and then there's some effort. and then more effort, and then they wake up and breathe heavy. Then they fall back to sleep. Central. There's effort. Effort. All the way through, they have a flat line, even during the effort portion. Then they wake up. There's the arousal with the chin tone. Big breaths. These begin with a central component, have 2 breaths at the termination of the event, which culminates into an arousal. Hypopneas are events where the airflow signal drops at least 30% for a duration of at least 2 breaths and is associated with 3% desaturation. So kids, really except for the central stuff, remember that it's 2 breaths instead of 10 seconds. Hypopneas are scored with nasal pressure transducers for diagnostic testing and with the CPAP flow signal during a titration. The AASM allows alternate hypopnea sensors, but you really need to use the nasal pressure transducer. I don't know how much you've talked about Medicare and Medicaid scoring rules in your other classes with Mr. Spruill. But the manual also permits the scoring of hypopneas requiring at least a 4% desaturation, arousals not included, meaning you have to have the 4% desaturation. Doesn't matter if you have an arousal or not. In the case that you have a Medicaid or Medicare patient, you need to score hypopneas with a 30% signal drop for at least 2 breaths long, and there has to be a 4% desaturation. If there's an arousal, it's fine, and it's not if there isn't one. Otherwise, you're free to score hypopneas with a desaturation of 3% or just an arousal. The manual did not used to have the 4% rule. That is strictly because Medicare has mandated it for their patient. And do you know what that means? It means that although the AASM has sleep experts whose job it is to figure out the best ways to tell if someone has sleep apnea and gives the rules, Medicare decides that that's not good enough and they make their own rules. So Medicare is such a large entity and federally supported and has the influence of that sweet, sweet cash that the AASM adds the Medicare rule into the manual. And remember, it's harder to score hypopneas with a 4% desaturation than a 3%. A lot of patients just have 3%. Why would the AASM include 3% if they didn't think that was, like the minimum that we can allow or the maximum that we can allow instead of 4%? Scoring hypopneas as central or obstructive is optional, but personally, that seems like a horrible idea not to specify which one, because that can totally change the treatment. Score them as central and obstructive unless your lab tells you not to. Hypopneas are considered obstructive if the patient if there's evidence of them doing any of the following: snoring, increased inspiratory flattening of the nasal pressure or PAP flow signal compared to normal breathing, meaning flow limitation, and I've got a slide of that. Or there is an associated thoracoabdominal paradox that occurs during the event, but not during pre-event breathing. So all of that means snoring, flow limitation, or paradoxical effort. Paradoxical effort is the chest and abdomen belt are going against each other instead of synchronously with each other. Here you can see normal breaths and airflow during N1 because these are slow rolling eye movements. There. So this is N1. That kind of looks like lamp. It's kind of thick for me though. The more they fall asleep though, we've got nice big breaths, but the more they fall asleep, their airflow is going down and it's flat until they arouse. There's the arousal. Chin tone goes up for that arousal and the legs kick for that arousal. You also have a desaturation from 97 to 88. You still have this abdomen. We expect effort to get a little less when you're asleep, but there is still effort here, right? There's still effort. Central, we want to have just almost no effort. And here's the chest. That's still really good. All right. The legs there, that's usually the body saying, hey, breathe, dummy. These also have, most of these have really good desaturations. This is a great example of flow limitations. Sometimes the nasal pressure signal just looks strange, or it might even have cardioballistic artifact from the heartbeat that actually pulses through the cannula when you put it on too tight. So that would be a normal flow, especially if they're not arousing or having any events. Otherwise, you might get something that looks like this, and this is flow limitation. So we've got normal breaths here, normal breath here. Look at this in the, see, this is the effort. Normal effort in. Here's normal effort here, but look at that. There's a little notch there. It doesn't affect this yet, though. But look here. There's a notch there in the abdomen and a notch in the effort of the chest belt. And now there is a notch in the airflow. The patient is slowly starting to obstruct more. That looks like an arousal there. And they take a bigger breath with bigger chest amplitude, no notch. As you go along, more notches. There's a little bit of a notch. Notch. Now it's cupping even more. And overall, the signal is decreasing even more. That's I would score that as an apnea right there. It's also a long desaturation. This is a long event because it's going from 93 all the way down to 84. Unless you got an arousal there, you could score this whole thing as an hypopnea. Look at this. The snoring is even coming in through the chin EMG. And here's pen blocking. That's when they're taking such big breaths it's going off the page and it can't go any further, so it just stops there. So that's part of the key of, is a patient showing just their normal respiration, or are they actually obstructing? Qualify it with notches in the effort. Are they paradoxing? Is the airflow like that? Are they snoring? Things like that are going to confirm that it is a real problem and not just a funny looking signal. We score hypopneas as central if there is no snoring, no flattening of the airflow signal, wherever it comes from, and no paradoxing effort. And the way they write that in the manual is to score a hypopnea as central if none of the following criteria met, which is just, what it was for the obstructive ones. Sometimes patients on oxygen might have hypopneas, but not the desaturation, because supplemental oxygen might blunt the desaturation because they have the oxygen there. There are currently no scoring guidelines for when a patient is on oxygen and no desaturation is noted. If the diagnostic study is performed while the individual is on supplemental oxygen, its presence should be documented in the notes. Here are a run of central hypopneas. These are not typical REM hypopneas that you see. These seem pretty bad, especially if you have central stuff like this in REM. That's pretty abnormal, actually. This looks like CSR over a titration. I think this kind of looks like we're on CPAP or something. It looks like airflow. We don't know where that airflow is coming from. This kind of looks like you've got someone just about fixed on CPAP, but now they're showing complex sleep apnea where it was obstructive, and now because of treatment they're showing some central activity. And this, when it happens in REM, remember REM respiration is taken over by a different part of the brain than regular respiration in non-REM. So when that happens in REM, in that respiratory part of the brain, that's not great. This pattern of, and you're going to hear it and you're going to see these words on the test, exactly the words, waxing and waning, or crescendo, decrescendo. Crescendo means to get louder or bigger, and decrescendo means to get smaller or quieter. That's a musical term. And waxing and waning, waning going down, waxing getting bigger. There are a few reasons for these kinds of respirations. One of them is heart failure, because the heart can't pump that blood anymore. So this is a way that it gets away with not doing it so much. But this is what you get. Scoring RERAs, respiratory effort-related arousals, is optional for pediatrics, but it may be something a lab you work for does score. Those are when there are at least 2 breaths that are accompanied by either snoring, increased respiratory effort, flow limitation, which we saw, or an elevation in the end tidal CO2 compared to normal breathing. Truly, RERAs they require a building up of effort. The belts should look like a staircase going up because their effort's getting more and more and more until that starts to wake them up. So here, this is a good example of the chest belt gradually gaining amplitude while the nasal flow has flow limitation and quite a big signal loss. That's definitely, I'd call more than 30%. There's flow limitation there. Something happens right here. Maybe they've got, and look, they're paradoxing too. But they were paradoxing before, so I wouldn't include that. And they're paradoxing after, so either the belts are wrong or that's a natural thing that they do. I'm sorry, that's not. That's something else. These two are the belts. And then you've got the thermistor and the cannula, so this is nasal pressure. But something happens right here. Maybe something clicks in their throat, and their effort just isn't really there anymore until they start to breathe more and more and more and more until they wake up with an arousal. Has to be an arousal because it doesn't have to be 3%. If it's 3%, that could be a hypopnea. Really, I think the reason we have RERAs, other than these instances where there are true RERAs, are when Medicare and Medicaid doesn't allow these kinds of events if they don't have a 4% desaturation. Then you can score it as a RERA. Although RERAs don't factor into the AHI, it does factor into the RDI, the Respiratory Disturbance Index, and sometimes doctors can massage that into getting a treatment. Monitoring hypoventilation in children is recommended during a diagnostic study and optional during a PAP titration study. Depending on your lab's specific policies, hypoventilation can be scored as a duration, like 5 minutes over a 50 millimeters of mercury, or in the case of the AASM scoring manual, at least 25% of the whole sleep study would have to be over 50 millimeters mercury. Neuromuscular weakness and other congenital disorders are some of the causes of hypoventilation. Here is some significant hyperventilation. It's kind of hard to see, but the end tidal CO2 stays above 60. That's this right here. It looks like 65, 65, 65, 64. That's very high. The nasal pressure looks pretty normal. It's not really doing anything. It looks like they might have some flow limitation there. And you can see also there are notches here in the effort. So that kind of looks like true flow limitation. There's not a snore mic, but there's these little things right here. That's the chin. And I don't see a heartbeat. That could be the heartbeat. It's hard to tell. That could be snoring too. But I don't think they quite line up with that. You have to line these things up. That looks more like a heartbeat. This is just another, I'm showing you all the ways that you can use all the data that you get to qualify if something's real or not. You want to make sure it's real. Periodic breathing can be scored like hypoventilation, either over a certain duration or the whole study. The manual says periodic breathing is when there are at least 3 periods or episodes of central apneas where there's no effort or airflow, flat lines, which they would last longer than 3 seconds and are separated by at least 20 seconds of normal breathing. Central apneas that occur within these runs of periodic breathing should also be scored as individual apneas, as they are individual components of periodic breathing. So 2 events are happening, the apneas plus the periodic breathing. You can see these instances of central apneas, but there's pretty good breathing in between. So it's not like the waxing and waning. They're not gradually getting bigger and gradually getting smaller. I'm not breathing. Now I'm breathing. I'm not breathing. Now I'm breathing. It's not gradually building up and coming back down. And this is a normal 30 seconds of sleep, it looks like. I lied. It's 2 minutes. Yeah, this is typical. Okay, so what happened was this is a Cadwell record. I used to use not Cadwell, Compumedics, and they treat the data as two panes. The EEG you can have that as 30 seconds. Then that's what this is. But all the respiratory stuff they've got it as 2 minutes so that you can see that. So that's misleading. Here's a 5 minute window of periodic breathing. Again, it doesn't have that waxing and waning. It looks like coils that are connected to each other by a straight wire. Usually after a central apnea, there's a big hyperpnic breath or a big breath to compensate for not breathing so long. This doesn't have it. It's just, I'm not breathing. No, I'm breathing. I'm not breathing. No, I'm breathing. Although we score arousals and not stage arousals, I 1 billion% suggest that you score arousals as you stage sleep in the 30-second window. You already have to determine when arousals happen when you stage to figure out what stage the epic is based on where the arousal is, so you might as well put it there. It's popular with technologists to score arousals in a 2 minute window. But the problem is you get into the habit of putting an arousal next to every hypopnea or apnea, even if there is an alpha present. You can't really see it there. So arousals are scored with an EEG shift, usually some kind of PDR for at least 3 seconds, which happens after at least 10 seconds of sleep. The difference between REM and non-REM arousals is that REM arousals require at least 1 second of elevated chin tone to score. Children can be very subtle in their arousals because the PDR is so slow compared to adults. It just looks like normal sleep. So be on the lookout for other hints in that like I was showing you, that an arousal has occurred, like additional movement of the legs or chin elevation, something that changes in the respirations that isn't the normal sinusoidal pattern. Here's a record of an adult arousal. I picked this because of the huge alpha PDR that they have. We enter with non-REM, got some slow rolling eye movements. Then all of a sudden, they wake up. Eyes are closed, and huge alpha right there. This doesn't have to be all the craziness that the ISR likes you to have with arousals. A lot of arousals are really subtle, and you need to confirm the arousal with additional data. So that's why it's so important to have all the sensors working so that you can confirm or dispute your suspicions. So this is what an ISR arousal would look like. The first time the signals get thick and crazy is really the only arousal here, although it looks like they're sleeping a little bit more. That's the issue here is I don't see great alpha, so maybe the patient doesn't generate a good PDR, but I'm not sure that there can be more than one arousal. I'd probably score this as wake, with just the first third showing sleep. The other stuff could be movement artifact or something like that. Here's an old study with a confusional arousal out of slow wave sleep. You see the big delta waves, and then all of a sudden all this dark stuff happens. This is a little unusual because there are still big waves here, which is and it's an arousal, but almost an awakening, which is an arousal that culminates into an epic of wake. But the patient is still sleeping while sitting up here. You can see some alpha riding on these waves. Right here, they're still got slow waves, but there's alpha on those slow waves. And the darkness of the wires that we see here could just be tension artifact, because since the patient is sitting up, they could be pulling on those wires, and that's what it looks like if there's tension in the wires. Cardiac dysrhythmias or arrhythmias are not as common in children as they are in adults, but they can still happen. I've seen them in a handful of pediatric studies, actually, and we monitor them a little differently with pediatrics. One of the silly mnemonic devices I used to use to remember the difference between tachycardia, which is a fast heartbeat, versus bradycardia, which is a slow heartbeat, is if I see someone dressed in incredibly tacky clothes on the street, I'm going to run away as fast as I can to get away from them because I don't want to have anything to do with whatever they're all about. On the other hand, if you've ever seen the old TV show The Brady Bunch, that was the slowest TV show in the world. Nothing ever happens, and when it does, that's not a big deal, but it takes the whole episode to get through it. So, tacky, run away. It's very fast. Brady Bunch, so slow that I fall asleep. A heart rate of less than 80 beats per minute for a 1-month-old and younger, or less than 70 beats per minute for a 1 to 2-month-old, or less than 60 beats per minute for older infants is considered bradycardia. Tachycardia is when the heart rate is greater than 190 beats per minute for a newborn and greater than 160 beats per minute for an infant. A lot of times it's common for tachycardia to occur in REM or during respiratory events. Even if you don't score those instances on the record, you should include them in your documentation. Premature ventricular contractions, or PVCs, which occur in a series or have more than one focus, or they come from one different cell, need attention from a physician. This means that if there is a run of 3 or more PVCs, that actually constitutes as ventricular tachycardia. Also, having more than one focus means the PVCs are coming from different cells and not just one as they commonly do. These are also called multifocal cells, focal meaning plural for focus. The focus is where the PVC originates. Supraventricular tachycardia is more common in children. They are scored with a heart rate greater than 220 beats per minute, and most episodes last at least or at most a few minutes. If there are frequent episodes or are longer than minutes, they require intervention. Here are a couple PVCs. They're huge and bizarre compared to the other little heartbeats. They stand out from the EKG. These are coming from the ventricles. That's why they're called PVCs. If they were PACs, they would originate from the atria and would actually resemble a pretty normal-looking heartbeat, except the rhythm would be off. And here's a run of premature atrial contractions, PACs, and the run is called supraventricular tachycardia. Supra meaning above, ventricular meaning ventricles, so somewhere above the ventricles, and it's fast. And these are PACs, and they're quick. Premature atrial contractions. These are a run of those. And you can tell this is SVT because it's not just a fast heartbeat, because you have clear PQRS T waves, PQRS T, and then this happens where there's supposed to be 2 different waves here, but there's just one. I don't know if it's a P or a T. QRS should be a T, but it's either a P or a T. I don't know. And then they get faster here. It gets up to 112 right there. That's a little behind, but sometimes the heart rate or pulse can be a lagging indicator. Limb movements are scored with pediatrics, and they need to be scored just like they are with adults. And guess what? That's it. Oh, these are long, but I've actually broken them up. These used to be like 2 or 3 slides or presentations, but I had to break them up a little bit more. So, let's study this material. I'm going to try and make every question that I put on these things what you'll probably see on the exam. That's why some of these are going to have more, because this is more of the stuff that you need to know other than the ones where I just put 4 questions in or something. All right? We'll work hard.